If you grab a seat, that would be great. A lot of excitement here. I think we're going to have a great conference. So this is our kickoff session, and we're thrilled with starting it this way. But I have to make a couple of announcements. First off, we do have a sponsor for today, so CP of the North Country. Thank you very much for sponsoring today's session. Thank you. And you should, if you haven't checked in, registrations up front in the lobby by the hotel. Today's session really is an opportunity for us to follow up on some of the work we've been doing with OMH and OPWDD over the past year. We've had a couple of other organizations working closely with us on the idea of looking at people with IDD as people and not labeled and tied to an organization, like not OMH people, not OPWDD people, and not DOH people. They're people. And then how the Medicaid system works and supports people is really key to what we're trying to accomplish here in terms of thinking about things differently. And we're excited because I think a lot of good work has been made, progress has been made, certainly between OMH and OPWDD. And both of the speakers here today are here to tell you a little bit about that, but we'll also have the opportunity to hear how the larger overview of the Medicaid program is looking to the future in terms of people with IDD, how we fit into that world, and hopefully some sort of charting of a course for the future for us on that front as well. So with that, I'm going to introduce today's panelists, and from the Medicaid program, we have the Medicaid Director, Amir Bassiri. Next to him, in place of Commissioner Sullivan, who was called away to the governor's office, was not able to make it. But we're thrilled to have Moira Tashjian, Deputy Commissioner. And of course, most of you know, and we're very thankful that you're here, thank you, the Commissioner of OPWDD, Kerri Neifeld. So with that, I'm going to turn to them and ask them to make an opening statement, if they would. And we have a number of questions that we'll get through, topics that we like them to hit on. We will have the opportunity for you to ask questions, but if possible, kind of hold to the end. I'd like them to, respond to some of the questions, but we can keep it interactive, okay? So with that, I'm going to turn it over to, who would like to go first? We did a lot of planning on this, just to,
stretch. Maybe I'll just come stand. It's a little awkward there.
Yeah. Sorry.
I'm the queen of awkward. Hi everyone, good morning. It's nice to be here with you. Apologies for my sound. I'm recovering from having kids. So I have a whole sheet of talking points, but I'm not going to go through them. I think you guys know that we have a lot going on, right? We released the strategic plan. We have a ton of projects going on with the strategic plan. Really focused on working collaboratively with our partners. It's really exciting and thrilling to be here with Moira and Amir, who are my close colleagues and also my close friends, and to be able to do this work with them and with you and this community is really important. We are working really closely, the agencies, OMH, OPW, DOH, also working with OCFS when appropriate to really try to break down those government silos. I know that it feels challenging in the field. We're all laser focused on workforce. Workforce is a challenge that I think we're experiencing across the health and human services sector. I think people understand that we feel it really acutely in this system for different reasons, related to how much we rely on our direct support professionals in every way, and that we don't necessarily have the same economies of scale that some of the other systems get to experience and get to leverage to address some of the workforce crisis. But also a lot of what we have in our strategic plan, a lot of the focus of our efforts on our collaboration with OMH and with DOH is how we can mitigate some of that need for such intensive workforce supports, right? We know things like technology, enabling technology, assistive technology, areas that we can, continue to integrate care, really focusing on the primary behavioral and long-term supports and services, are also ways, right, over time that we can continue to rely less and less on our, on our in-person workforce. We know that direct support professionals will always be the backbone of our system. They will always be critical and integral to everything that we do. But I think we also know that we have an over-reliance on staff because we have not necessarily embraced some of the other innovations and technologies that would help us to really free them up to do the work that they need to do. And I say that taking responsibility as a state agency as well for our regulatory structure and our rules and regulations that we put out, and we have made an effort to continue to look at the rules and the regs and how we can take down what doesn't need to be what doesn't need to be there, really focus on creating a system and creating a regulatory and rule framework that supports quality of life, that supports quality outcomes, and is less focused on compliance. And I think that's a long-term journey, right? So when we talk about this, these are not things that are going to happen overnight. It's not like the magic pill of show me the one reg that makes your life so difficult and we'll change it, right? It's not about that, right? I think it's about a long-term shift in the way that we see ourselves as service providers, the way that we see our system. And I think that shift has to be done in conjunction with our partners at the Department of Health and at OMH and within the other systems that we all interact with, because we are so interdependent on each other and really, making that shift, looking at that whole person in an integrated way and how we can continue to support the whole person. And I think that will help us to, continue along to achieving those goals that we have laid out in the strategic plan, which are really all designed to enable people with developmental disabilities to achieve their goals. We were talking yesterday to PBS. They're doing a documentary on sort of the national picture of the workforce crisis when it comes to working with people with disabilities. And we were talking about our DSPs and just how interesting being a DSP is, right? Because every day can look different, right? And depending on what environment a DSP works in, they're working with very different people, right? People have very different support needs, going from the total care all the way, to somebody who is relatively independent, needs minimal supports, and how that's the picture of what our system is responsible for, right? And it puts us in a really interesting but also exciting opportunity, I think, again, to try to pull those levers, to become more reliant on things like technology, more reliant on innovation, so that we can continue to shift our system in a more progressive way. Some of the things that we're really excited about right now, we just released $13 million for employment grants, so that we have now in each region, and in two of the regions, I think we have two providers who will be providing vocational training and assistance to people with developmental disabilities, but outside of sort of the spectrum of what we cover in the HABs, through Medicaid. So this is non-Medicaid funded, meant to provide training and technical assistance to people who are looking to develop employment skills. So again, we're trying to focus on where we can help people to achieve some of those goals, employment opportunities, really being able to fill the pipeline. We have a workforce crisis, not just in our system, right, but across the state. Employers who need staff, and we have a lot of people who want jobs in our system. So really trying to think about employment first as an opportunity for people. We're finalizing, finally, our supportive RESHAP grants that were released. The RFP was released quite a while ago. So we're finalizing those opportunities now, really, and they're focused on seeking innovation in housing. So really focused on things like technology, ways that we can help to support people moving from supervised group homes into supportive or into family care, and eventually into the community, and into supportive housing or independent housing. That's another area that we're focused on. We're doing a lot to look at our Article 16 clinics. We're doing a lot right now. Obviously, our managed care study is underway, continuing to look at the way that we can continue to support an integrated, holistic approach to the work that we're doing. We're doing a ton of collaborative work with OMH, which I'm sure Moira will also talk about. We're really trying to focus on individuals who have developmental disabilities and also either psychiatric disorders or behavioral health challenges. Doing a lot in terms of looking at children, especially in that dual diagnosis area with children. We're working with Upstate Hospital. We're working with one of our providers on creating a specialty hospital for children with autism and behavioral health challenges. We have, I think we're on the verge of releasing the home and crisis behavioral intervention teams. And OMH was really generous with us and has been collaborating with us to use some of their money to create 2 teams that are for children that are meant to deliver crisis intervention directly in the home and prevent some of that penetration into either hospitals or more residential treatment centers for children or residential treatment facilities. Really focused on for children especially, focused on creating community-based services, wraparound supports for families, so that we can avoid some of that crisis, the crisis involvement that we see. Obviously, CSIDD on our side, we're continuing to work to make sure that that is available statewide, and that resource centers are available statewide. And also some other really exciting partnerships, transitional housing, things like that with OMH. So I'm totally off on talking about and not making a ton of sense, but I'll, I don't know if my colleagues want to say opening remarks, or you want to go right into
I think we can, make a statement. Have a mic now, so you're good.
Hi, everybody. I just want to echo everything that Kerri was just saying. It's very invigorating to almost restart and take a step back and look at the whole person. Oftentimes, we kind of get stuck in our own little silos, our own little worlds, but individuals are complex. We have multiple needs. An individual who has a mental illness might also have an IDD and individual challenges in getting the services they need from both systems because they get stuck in one system or the other. We have to continue to look at individuals as a whole, not as just one part of the whole. So I think that I can honestly say that our commissioner and Commissioner Neifeld here has made a commitment to make that happen. We were very fortunate this year to receive $1 billion in our budget from the governor to put together a comprehensive mental health plan. But that comprehensive mental health plan has to include individuals who have multiple needs. So as Kerri was mentioning, we're going to be doing things like expanding the HCBI. Some of the other programs that we're looking at is our transitional step-down program. So anything that we feel that there's a gap in services and for IDD as well as mental health, we're going to try to tackle that. We want to really continue this partnership, which I know is happening, but we also have decided this year to, again, more of a restart with our Inter-Office Coordinating Council, the IOCC. The IOCC started years ago after the 3 agencies, OASIS, OPWDD, and OMH, were originally under one umbrella as the Department of Mental Hygiene, and then went into 3 agencies. The 3 commissioners have been working really closely to make sure that we come back together in a way we haven't in a very long time. We've had a couple of these collaborative meetings. We're meeting with the local government conference of local mental hygiene directors, as well as our own teams as to what are the areas, where are the needs, and let's get it moving. I'm glad to be here today. Thank you.
Thank you for that. And just for folks that weren't able to participate, we partnered as CP with UARC New York, the Mental Health Association, and NYAPers, and I see some folks from those groups here today. The priority being that we really have seen not just over 50% of the folks in our clinics having a coexisting mental health diagnosis, but the folks in our homes and the need for behavioral support, certainly in crisis management, are really important for us. We've gotten the attention of the Hospital Association because of the real lack of a systemic response when folks in crisis show up there. So it is, I think it's a, I won't say a perfect example, it's a bad example of where we really need to look at how the whole of the service system works together to support people with IDD, and how are we able to actually support them in ways that are efficient and good for them. And I think that's been the priority of the work that we've done, and it led to the idea of having today here sort of this larger discussion about what we're doing. So Kerri and Moira touched on some of the work that they've been doing. But I think one of the things that it brings to mind when we talk about crisis management and thinking about people with IDD, we have a clinic system right now, and we were New York State that has been developed through years and years of folks, CPs are with Article 28s, Article 16s, and you have Article 31s, and they're struggling. There's no doubt about it. Financially, we're not able to really support folks. It takes more time to support people with IDD. The payment structure has never been revised. The APGs haven't been increased. So one of the questions that you could comment on is, what about our clinics? Where is that in the thinking for the future of healthcare for people with IDD? Are there thoughts about how we support the clinic structure, support that point? Because it is critical, and it's a critical part from a primary care perspective as well as a specialty care setting. So if you could talk a little bit about the clinics and the clinic system and your thoughts on that.
Yeah, I can start with that, and would love to hear from Kerri and Moira as well. And good afternoon, everybody. Amir Bassiri. We recognize some of the challenges that the clinics are facing for the level of care for the population served. I think I've seen it firsthand in the capital region, and it's evident that there's more we can and should be doing to recognize, what the clinics are dealing with from a workforce standpoint, especially some of the Article 28s that are providing primary dental services. We know that the reimbursement rate, and specifically the APGs, are not reflective of the cost that the clinics are enduring to provide care. So this is definitely a very high priority for the Medicaid program. We did some things in last year's budget on dental and trying to expand access specifically for the IDD individuals who are seeking dental services or dental surgery. Through the 1115 waiver, we are exploring ways to identify enhanced payments through the primary medical home model, specifically for those that are serving IDD individuals. And on the Article 16 side, I think we do see some opportunities to even the playing field, for lack of a better phrase, on some of the capital reimbursement and the other rate components. It is definitely a very high priority. Fixing the APGs is hard. It's really hard. And there are short-term solutions, and then there's long-term solutions. I think in the short term, we are trying to find ways to increase reimbursement quickly to account for the services being provided. In the long term, it's a big priority of mine to really do an overhaul on the APGs, but that will take some significant time. We would want to get stakeholder input, and so we do want to chart a path forward to doing so. But I would say in the short term, this is one of our key state of the state and budget priorities, specifically for IDD, and I can tell you it's a big focus of all of ours on the panel here today.
I was just going to talk about our CCBHCs, which are Certified Community Behavioral Health Clinics. Typically, the IDD population was not involved in the federal demonstration projects, but the RFPs that we're rolling out right now, we do have language in it that is going to create an IDD mental health priority for services for the CCBHCs. Again, it will be touching outpatient services and will provide really across lifetime service, lifespan services. It should be person-centered, family-focused as well. So, this is the first time we've been doing this, and tied into that is also a crisis component with crisis behavioral health as part of the CCBHC. So we're emphasizing, again, priority, which we've not done before, nor has the federal government in their demonstration projects up to this point. So that's another way we're trying to address this need. So I just want to emphasize what Amir said, and I just want to also be very clear, because I think he kind of glossed over it, but when Amir says he's seen firsthand, right, some of what's happening in our Article 16 clinics, he's actually been out and spent several hours at a local Article 16. Greg was kind enough to host him and his team, and see, really what the challenges are. And I think really, truly, the Medicaid team recognizes the incredible value that the Article 16 clinics play And I think we all know the challenges that we have. And when we talk about ensuring whole health, right, for an individual, right, and that we're responsible for the whole health of an individual, but we have very, limited leverage over certain pieces, right? This is an area that the Medicaid team has really been a true partner, right, in wanting to really dig in, whatever the analogy, pick up the hood and look at all the, tinker around under the hood, looking at stuff and seeing where we can fix things. And some of, the challenges that we're facing are structural and longer term. But again, right, some of them are shorter term. And I think on the OPWDD side, we just had a conversation with Mike and Eric and a few others, looking to reinvigorate some of the work that we're doing internally on Article 16s, looking at, again, right, where some of the regulatory structures are shorter term fixes to some of that, and we're trying to push some of that, and some of it is, there's multiple steps to some of these remedies, but we're also committed, right, where we can with the existing system that we have, make some of the smaller tweaks that we need to make life a little bit easier, while we're keeping an eye on the longer term and how we can continue to work towards the longer term vision. And I think another space that's really important, we've been having conversations with the Medicaid team, is around integrated licensure and how integrated licensure can be a benefit to folks in our system, and it truly makes sense. Again, when we're talking about serving a whole person, when we're talking about a holistic approach to an individual, we're talking about long-term goals like employment, housing independence. We can't even begin to get there if we can't get some of these foundational pieces ironed out, like somebody having reliable primary, dental, behavioral, and long-term services. And so we really are looking at a team of folks who are committed to doing this work together.
And I think that's absolutely great to hear. I know we've been struggling as a field for years, but the integrated licensures and administrative staff, those kind of things really will make a difference on the administrative side. But again, it's looking at the whole person, making sure that we've got a system set up to do this. So it's very encouraging to hear that you're thinking about it and working on that, and getting out to see our guys is probably the best way to figure out what it really just makes you understand when we're asking for something. I don't conceptualize things well. Now under the hood, I'm guessing what's going to come with but I think it's very helpful, very, very good to hear that you're doing that. The sort of next thing, you touched a little bit about the crisis management. I think when we talk about escalation in crisis, is there anything happening or anything that you're thinking about from the crisis centers, I think, Moira, but as well as that in terms of working with the hospital system? We've got a complex care group that we've been part of with paintings and other groups. Is there anything on that front in terms of looking at the hospital discharge planning system that you're considering or thinking about, particularly with crisis management issues?
Yes.
Okay, let's not run to the next one. Yeah.
Next one. Yeah, absolutely. I think it's another area where I think we're seeing collaboration amongst the three agencies. Right. Obviously, DOH has been doing a lot of work on the 1115, and there's I think some opportunity within the 1115, to really see some of this integrated, right, especially between the hospitals and the two systems. But then also, with OMH, we've been doing a lot of work at looking again, right, at some of those individuals who are duly diagnosed, what's happening to them. Discharge can become, very troubling and very difficult and protracted, as you guys know very well, right, where we have people who are lingering in hospitals for months and months, and unfortunately sometimes more than that, before there's a real opportunity. And some of that is, when you think about crisis, right, you're talking about the acute crisis that the individual is experiencing, but then there's also, right, against the backdrop of the crisis that is happening within our system, right, and our system's inability to be able to meet some of those needs because of the crisis that we're experiencing. And so just really trying to think about state operations as a discharge resource. But some of the exciting stuff that Moira can give more details on is, transitional opportunities. We're seeing some of that happen within, with some of our providers already, kind of creating some of those transitional opportunities. And, we spent a whole day down in Brooklyn, me and Moira and Dr. Sullivan, folks from our teams, looking at what they're doing at the Kings County Hospital there, and they're doing some work with one of our providers as well, to create step-down opportunity. How can we replicate that? That's where I think that there's some opportunity with DOH through some of their vehicles as well. And then some of the work that OMH is doing with their $1 billion also can help to replicate some of that. So I'll let Moira sort of say more about that, but.
Sure, thank you. I think there's 3 areas that I want to touch on. First is 988. As part of the statewide 988 hotline implementation, I hope you all know what 988 is. Does everyone? Okay, 988 is it's the behavioral health equivalent to 911, really. But it's also a number that people can call and really just talk to the individual on the other side of the line to find out how they can work with their family, with their loved one, or if they need the service themselves. It's not just an immediate rush to have mobile service sent out to you. So as I was saying, as part of the implementation of 988 hotline and the crisis continuum development, both OPW and OMH have partnered with the University of Rochester to support and train crisis response continuum throughout the state for both systems. And Project ECHO also is training for crisis workers and mental health workers, other human service professionals to increase the knowledge about IDD and really the intersectionality of the co-occurring mental health and IDD needs. And then lastly, we're looking at, how do we expand any kind of knowledge base across both of our systems. So that really ties to the 988 piece of it. The next piece is talking about the emergency rooms and where people get stuck. It's not just in the emergency rooms and the CPAPs, but also on inpatient units. It's those periods of transition. We're in the process of creating a new level of care at the Office of Mental Health, and it's a transitional step down. It's a 120-day program that's treatment focused for individuals who are transitioning from wherever, whether that's the street, the hospital, inpatient, prison. It's a place to go where you're going to receive treatment services, but also you're going to be able to have staff work with you to get to that next level of care, wherever that next level of care is. When an individual is leaving a hospital, what we're also doing is tying to those hospitals CTI teams, critical time intervention. So individuals will be assigned a team, and they can be carried by this team up to 9 to 12 months, depending on the needs. But that staff person will be providing, that team will be providing whatever those transitional needs are during that period of time, and connecting the individual with what the most appropriate services are for them. These 2 things are happening now. We're rolling out RFPs, and really we want to have these up and running the RFPs will all be out before the end of December. So I think those 3 areas really will you'll see significant changes, I believe, in your ERs, your CPAPs, and your inpatient units, and your prisons. I mean, we've struggled with folks who are on the street. We have a huge homeless program in the state, but there are individuals who are duly diagnosed and living in the streets, living in prison. We have to also remember that that's another population that we have to serve, and we have to provide them with what they need to survive in a whole life in the community.
As you guys were speaking, one of the things that comes to mind is the data, looking at data, getting data, pulling it together. And we've had a heck of a time. We don't have good data. We don't. I don't know that when we work with the state, we try to get the Medicaid and Medicare, and most of our guys are really eligible, more than 50% are really eligible. So when you think about doing anything at the state level, the problem I think we've had with the Medicaid system is it tends to be looked at as, no BD spend, no wage spend, and by silo. So we cross over. This particularly was true with our CRPs. If you look at the CRP program, it's an education dollar, there's the BD dollar, and there are other costs related to that just kind of got blended. It was very difficult to get any efficiencies there. So the question, it's a long entry, but the question is for the Medicaid program, how are you looking at, or will you be looking at data differently in terms of the total spend for And how are you looking at some of the programs in terms of their efficiency, in terms of Medicaid savings, as well as possibly working with the federal government on getting any credit for, you know, what you're saving for the Medicare system, if there is anything that does generate savings? It's a lot, I know. So take it an hour.
Sure. I'll start with the data sharing.
Sure.
This has been a pain point for me since I've been in the role. We are not good at sharing data. A lot of red tape to cut through. And I think we've made some headways with OPWDD and creating opportunities for them to look at the data differently. We're working on things with OMH, and we have a broader Medicaid enterprise roadmap that's 5 to 10 years to really transform the way we integrate data, share data, and unfortunately it's not in place right now, but that's where we're going. And in the interim, we're trying to create environments so that people can analyze the data in various ways. When it comes to Medicare, it's a little trickier. And the reason is that we can't get the PHI data from Medicare absent our duly integrated populations. And when we look at our spend for duly integrated populations, we can certainly analyze the data in various ways, from utilization to spending to patterns and providers. But ultimately, the real savings that you alluded to comes from integrated managed care plans that offer both the Medicaid and Medicare services under one component. And we have made a massive effort to prioritize integrated plans, starting with duals that are already in mainstream, aging into 65, enrolling them in the plan for which they're already in, corresponding with Medicare. There's a lot more we can do, but it does require commitment to managed care. And ultimately, that's where the savings would be for the federal government and for the state. So we are not necessarily looking at our data and trying to identify efficiencies in, spending for the IDD population. We're just trying to actually better understand the data and how we can support the providers. I mean, it's somewhat embarrassing to say, we don't have the best data. We don't know enough about the people that we serve. And ultimately, that's what one of the primary goals is of the 1115. To have every Medicaid member assessed for their social care needs and their health care needs, so that we know what risk factors they have. We can connect them to the providers, either community-based organizations or other clinical providers, through an integrated feedback loop based on those assessments. So we're really trying to enrich the data that we have, as opposed to necessarily analyze it for opportunities for efficiency. There's a lot more we can do with the data, and we've made incremental progress and a lot more to do from the Department of Health standpoint to make it easier for not just our other state agency partners, but providers, stakeholders, all to look at the data and see how they can use it to better care for our members.
Great.
Just want to add one more thing about data on there. With all of the RFPs that we're putting out right now, there is going to be a requirement that individuals share data with us on a pretty regular basis, so that we can start identifying, as Amir was saying, where are the gaps, where are the holes? What can we do differently? What can we do better? So, we're hoping that having that data will give us a different kind of picture than we've had in the past.
Yeah, so we're doing the same thing with all of our grant opportunities that are coming out. We're really building in, and we have a pretty robust relationship with UMN, as all of you know. So certainly evaluating all of the ARPA spend, UMN is doing that and really looking at outcomes so that we can begin to see, we're spending dollars here, are we actually seeing the real life outcomes for people? How regularly is it working? Can we continue to do this? And a lot of what we're doing, in terms of the grant opportunities that we'll be providing over the course of the next several years, with the goal of measuring those outcomes so that we can then come to the Medicaid program and think about Medicaiding certain services that maybe aren't now. On the Medicaid data side, I think there's two different pieces to it, right? There's the sort of the aggregate level data that we're trying and we're working with the department on, being able to have access to the full picture on an aggregate basis for our population. And we're making great strides there so that we can be making data-informed policy decisions, but then I think there's also the acute, right, individual PHI level data that I know like our CCOs struggle with, only having half the picture, right, of an individual and where their spend is and what's happening, right, and not being able to see encounter data and things like that, and that's another area, that we're partnering on trying to solve some of that, so that at least on the individual basis, right, we can be making some decisions or tailoring our services to ensure that we're supporting both sides of a person's life. But so it's complicated, but I think the two different sort of tracks for the data is important.
And it's critical for us as we move forward and we think about, the field as itself doesn't have the data for clinical protocols to really be developed based on anything other than our best practice. And we've been struggling for years, so to hear that you're working on it is good news. But I guess the segue for this is that we do have a project, and we've talked to you folks about this before, our telehealth project, which is it's innovative in the sense that it's something new for us. It's generating data. We believe that there are system savings, and how we account for those, who gets credit for that is difficult, but we know it's generating significant savings for a $13 million investment in the infrastructure fund. Conservatively, we'll go 60, when you go up to 110, whatever the number is, there's significant savings of return on that investment. How does the Medicaid program support innovations like that and making sure that those can continue? What do we have in the future for that?
Yeah, I'm glad you mentioned it, because that project is near and dear to my heart. In the statewide capital grants, it was the largest project we funded that year. And I think, I'll be honest, the Executive Review Committee never thought that 5 years from making that approval, we would be struggling to figure out how to pay for it. We never realized that this was going to be a subscription-based service, right? We thought the infrastructure and the partnerships that would be developed would be able to self-sustain it. That said, Medicaid doesn't do well with subscription-based reimbursement. Certainly not in a fee-for-service environment either, right? There's no code for, oh, that's my monthly subscription, so we're going to pay you for that. So this is another big priority of ours because we believe in station and we believe in telehealth generally, and the value that it can have for improving access and improving the quality of care. Certainly, yes, there are savings. Whose savings is it? Is a debate we'll have till the dawn of time, but are people getting better care is what is most important. Keeping people out of emergency department settings or inpatient settings is a good thing, and we're going to find a way to pay for that. We just don't have that infrastructure in place yet. I don't know that any state does, because we've been asking, and we're fighting with CMS. We're going to figure out a way to sustain the Station MD model because we believe in it. And ultimately, back to the savings, I'm saying this, but there's this argument you're saving money for the state, and they're partially true. If you're keeping people out of the hospital who we pay, you are saving money for the state, but really you're saving money for the hospital, right? Because no one in this room even would say that we pay adequately. I have never heard someone say to me, Medicaid, such an adequate payer. So, in essence, the hospital is losing even when that care is delivered in the hospital. So, but in reality, these are some of the good things about a managed care delivery system. And there are a lot of problems with our existing managed care system. Moira can tell you a lot about them. And no one is saying it's a panacea, but those type of innovative shared savings arrangements and value-based payment opportunities, they really only exist in managed care. We don't have a way to account for the savings you're generating in the fee-for-service for the providers. So we'll think and explore various ways to do that, but it is something that's important to recognize as we go forward with some of the innovations in telehealth and care delivery that are in the best interest of the member.
So just to build on what Amir said, I don't know if Station MD's in the room, but I'm a Station MD super fan, so very grateful for the work that they do, and you know, it was you know, being with you all with CP providers, watching Station MD actually happen in real life and seeing it, that was just a very cool experience. So we are very invested in you know, Station MD, other providers that provide similar services. So I'm not supposed to be promoting any specific brand, and telehealth in general, but we are looking at, you know, we're looking at sort of the longer term solutions as well. I think we know we need a short term bridge, right? Because we have funding that's going to be running out, and we certainly don't want to lose the gains that we've made. And we know, right, even just going back to our workforce crisis and some of the challenges that we have, right, when people can be served in their homes, right, that's one less staff person that has to be called in to go to the emergency room for potentially 3 days, right? Or how long, and maybe that leads to an unnecessary hospitalization or a slew of unnecessary tests that are traumatizing, right? There's a million ways that this also benefits our system and not just the hospital system. But we are also looking at, and I spoke to Kate this morning, I think everybody knows that our waiver amendment was approved. And one pretty cool piece of our waiver amendment was a home enabling supports allowance. We think for people who live at home, not in a group home, but live at home in the community in their own home with a family member, that the home enabling supports allowance will be able to cover that subscription service. So this is something that we think can keep people in their homes for longer, keep them independent for longer. That's certainly an area that we believe is eligible for this expenditure. We are looking at whether or not the costs of the subscription service are baked into our understanding of the cost of running a group home. It's baked into the CFRs. Either currently, if we can pull it out and understand that cost, or if we need to make an adjustment going forward so that we can pull out that cost. So that eventually, and I know that we can spend a lot of time talking about our rate making system, and you know, that you won't see that money for a couple of years. But you know, trying to do the work now to make sure that we can actually isolate those costs so that they can be built into the rate and reimbursed as part of the operation of a group home. And then also, you know, we have learned so much from your experience that we're even looking at it for state operations, right, and how it can benefit in state operations. So just want to give a kudos to you guys for being innovative. You know, 5 years ago, seeking this opportunity, and really, I think, doing much more with it than we really ever imagined. So.
That's great to hear, and Station MD full commercial is in the house, they're here, so we're glad to see them, and thank them for being here. It really is a terrific project, as you're mentioning, and it is about the changes in the quality of life for folks in the homes. It's been a good experience, but I think if you're just a little step ahead, and I did want to get to it. I think the idea of integrated care, managed care, whatever we want to call it, but care coordination at different levels, plus the experience that OMH has had, I think would be of interest for folks to hear in terms of that experience, but your thinking as well in terms of you know, how, you know, the future for Medicaid is in terms of what it might be for the IDD population in terms of considering a move to integrated care. We have a session later today where we're going to have a broader discussion on that, and really hear from the folks that are looking at this, you know, how different models, and hear what they're thinking. But your thoughts on this would help us as well. Think about, you know, what we should be considering.
It would shock me if you guys didn't know my thoughts on this, given how much I'm asked about this, but I'm happy to talk about it. You know, I think this is a very important policy question for us. It's obviously been debated for a long time, right? A decade at least, if not longer. But you know, when we talk, you know, just the conversation that we're having today, right? I mean, it's evident where these silos between our agencies, between payers, between whose budget is what, really are an impediment to us really serving the individual as a whole person, right? Again, right? Person is, we have our anti-stigma campaign, right? Like beyond my developmental disability, a person is not their developmental disability, right? In our agency, and we are also guilty of this as well, of having a myopic view, right, of who we're serving and how we're serving them. Even, you know, when we're trying to have, I'll leave it at that. I think it's important that we, as an agency, look beyond just the services for a person's, you know, developmental disability. What are those long-term supports and services, and how can we be responsible for ensuring equity and access to primary, behavioral, dental, And that doesn't mean that OPWDD is fully responsible for all of that, right? We're responsible to our partner agencies, right? And you see, right, OMH has been a tremendous partner, everything that they've done. They recognize, right, that their system also feels the pain when it's not equipped to serve somebody who's got a dual diagnosis. And we can be a partner to them in that, they can be a partner to us. And so I think, continuing to build avenues for that partnership. And we would be naive if we didn't recognize that the payer, right, or the person who's, gonna be seeing cost savings because of some of these innovations wasn't a motivating factor in how we, so I think we have to look at that. Folks know we've contracted with Guidance to do a study on managed care, to understand the experiences of other states, to provide some education. We've just completed last night a round of stakeholder engagement where we've had some question and answer sessions, some dialogue. We really designed, and I've heard feedback in both directions of whether it was effective or not effective. You can't help yourself.
You can't, right?
We designed the questions to not be saying, how do you feel about managed care, right? Because it's a yes, no, it's also a loaded question at this point in our field, but really, how do you feel about the supports and services that you're receiving, right? Are you getting what you need from OPW? Are you getting what you need from your primary care doc? Are you getting what you need from your psychiatrist? Do you have a psychiatrist, right? But do you need one but don't have one, right? We're trying to understand the experience of the system, and then through the research that we've asked Guidehouse to do on our behalf, looking at other states, looking at other countries, looking at other payment models, would or would not managed care help, and then how, right? So I think we, as a system, need to have an informed conversation about what are our challenges, where and how managed care could be applicable. And Amir has said it, right? It's not a panacea, it doesn't solve everything. But potentially, right, it creates a vehicle for some shared savings, and some shared reinvestment in a different way. And some innovation, right? But I just don't think that fee-for-service in a very, right, what's the code, what's the service you're providing, what's your billable unit, how many minutes did you spend, right, doesn't kind of create that freedom. I know that OMH has had a challenging experience, right, that they're trying to work their way out of now, and it's obviously been informative to us. I was in the governor's office for years watching that experience, right, and it's obviously informed me in my thought process on this. And I think anything that we do will be informed by the challenges and the successes of other systems, but I know Moira can say more about.
I think we have to take a step back and look, there's good, bad, and ugly in everything out there, right? So I don't want to say that it was a horrible experience, it was a bad experience. There's a lot of good that comes out of it and continues to come out of it, working with the managed care companies. There are also some struggles. I think it would be fair to say the amount of companies that we work with is part of the challenge. And the other piece is accountability. We're all here, we're mission driven, and that should be our first and foremost thought as we move forward. And sometimes I think we feel that that's forgotten with the managed care company. If everyone needs to be looked at as an individual in individual care. So that's something we continue to work with. We're working closely with Amir and his team, and we'll continue to do that, to look at how is the best way to get through this. And as I said, there was a lot of good. We worked with some managed care companies that really partnered with us, were innovative, and brought their case management teams to do some creative work in opening up some programs in New York for individuals who are homeless, who are on their caseloads. So I think, it's not one or the other. It's not good, it's not bad, and sometimes, it's ugly. So I think we have to be honest with all of that you don't just throw it all away, the baby with the bathwater there, as the saying goes, kind of like and we'll continue to work with you, so.
Yeah, I just agree with everything Kerri and Moira said. Ultimately the question needs to be asked, what do you want managed care for? There's a big push now to do managed fee-for-service, because everybody likes a fee-for-service rate that they want in managed care, and that's honestly a very inefficient structure, right? We're paying health plans admin to tell them what to do and who to pay and how much to pay them. And that may make sense in certain instances. To Moira's point, we don't need to do that for 13 private companies who have more capacity than we do. Somewhat defeats the purpose, but that's where we are, and accountability is certainly something that needs to be addressed, and that we're working on. Challenge having so many plans, but it is a big challenge. The interesting aspect with the IDD population, we have 40,000 IDD members in managed care today, and I would wish I could talk to each one of them and understand how their experience is. But with respect to the OPWDD system and moving into managed care, it is novel, it is new. The rules can be set specifically on day one for the population and for the goal that we have. And this is not my team's expertise. We really do look to Kerri and her team for the subject matter expertise, the design of the care model, what needs to be in place. And ultimately, if there is a model that we can all agree on is in the best interest of members, we're going to do it. We do see opportunities. We have learned a lot from the experience OMH has had in behavioral health and the HIV/SNP population as well. I mean, ultimately, we see all of our members as our members, regardless of their condition, and are very much prioritizing person-centered care. And this is an opportunity as we go further to see, the results of the study and the analysis that we do want to be supportive of what is in the best interest of the population and the system at large.
Thank you. That's great. So, throw a little kerosene on the fire to bring up managed care. I think one of the things that, again, you're touching on is the way that we've organized today is to have this discussion with you. The next session will be trying to get to what is it we want to solve. We're going to talk about where is the system now, what is the future of the system, what's happening in the IDD community, what do we see that's working, what's our hope for the future, and where do we go. So the session after that is trying to answer how does it or can it solve it, what can it do? And I think that's the thinking that we've got right now, because I know there's a lot of, let's say, divergent ideas about what integrated care can be, and I think that's really something that I think we all got to come together and come to some sort of position. We can't just say no, and I think that's the point. One of the key points is we're not going to get anywhere if we just say no, that stinks, it's not going to happen. When Washington just says no, and we see what happens. We're the same place. We can't just say no and expect something to happen. So let's open it up for questions. I'm sure there's a couple of comments, questions in the room. We've got about 15 minutes for it. So let me call on someone I think who's got a question. We'll go. Anybody want to start? Oh, Pat. Oh, go ahead.
Bruce King with the Alliance for Rights and Recovery, formerly Appers. First of all, I want to say thank you to Mike for leading a lot of these efforts. We've been working with CP State, Harvey, myself, and Pat to work with CP State, Hayes, and the art to really look at that intersection between mental health and IDD. Within that work, a lot of the questions that kind of came up, especially considering the historic $1 billion that was injected into the mental health field. What sort of work is being done on the training side to guarantee that more of these services that are coming out through this $1 billion and a lot of other services from OMH side will be able to support people who have both challenges in the future? I know we've talked a little bit with the OPWDD side about transforming or amending our peer bridger model to help support people coming out of the hospital, and we're thinking especially in crisis services, that quick need to get the first sort of engagement, be allowed to support people the right way, the right services. Can you talk a little bit about that?
So, I think We start with even just our conversations and learning from each other about what we don't know, right? And that has to then permeate into our provider agencies and acknowledging, again, what we don't know. So there's cross-training we're looking at. I talked a little bit about Project Echo, where the training would be provided to our 988 providers. There's also something called Project Teach. Project Teach is a program that allows pediatricians to call mental health physicians to get advice on working with individuals who have mental health needs as children. Again, I think that's an area where we're going to be expanding. We're looking into some cross certifications to duly train individuals to be able to work in both populations. We talked a little bit about, we just touched base about the SUNY Upstate program. We are working with SUNY Upstate in developing a specialized multidisciplinary inpatient program supporting children who are duly diagnosed with IDD and mental health. This program is going to be providing crisis services and specialized psychiatric and behavioral health treatment. So we're going to be learning quite a bit from them as well, and training coming out through there. Again, I think it's going to be a process. We don't know what we don't know yet. So we have to work together to develop this training. At the Office of Mental Health, we have a training arm. We've already talked to them about what do we do different? What are the resources out there? We also have CPI, which is our Center for Practice Intervention. And we've begun conversations with them about developing some training tracks that would be available for providers throughout the community.
Thanks. Next, I'm sure there's another.
As we move to managed care, what's being done to ensure that realistic outcomes can be developed in order for providers to be able to deliver services? The other is, if you look at district as a model, it didn't do well with picking outcomes for our group, and it would have been a real problem if they were instituted as district as an act. So what's being done to look at those outcomes to make sure they're realistic and attainable for the provider agencies that are working with those?
Thanks, I think that's Jerry, I can see. So thanks for the question. I think Amir hit the nail on the head, right? We, as we continue to talk about what a potential transition to managed care could look like, if that's a decision that we make, and in what way, right? I think there's lots of different ways managed care can be beneficial here, right? The old conversation was around an eventual mandatory transition for all, right? That's not necessarily what we're talking about, right? It's pretty wide open. And I think that the opportunity to set realistic outcomes that are meaningful to people's lives, that's all there, that's all opportunity, right? We don't have to back into any type of formula. We can create the parameters, right? We can write the language into contracts about outcomes and then have a very robust role in holding people accountable. So I think it's a great question. I think it's important. I think it's the forefront. And I think if you ask the question of why managed care, which Amir said, right, it's about those outcomes, right? And if managed care can help support those outcomes that we're all looking to see for people, which are very different, right? For person specific, but can I think be generalized, for the purposes of managed care. So I think you're right there, that those are the things that we have to decide and talk about as a community, to make sure that we do this in a different way. It's not about cost savings, right? It's about, managing the benefits to leverage them to help people with developmental disabilities to achieve what they want to achieve in their lives, right? That's what all of this is in place for. I guess I would say, on DISRIP, I think DISRIP is an example, right, of why it would need to be different, why it would need to be designed for this population, with this population in mind, heavily, co-managed by OPWDD and DOH together, right? I mean, district was an example of something that ran through the hospital system and surprise, right, benefited the hospital system. So, okay, we learned from that when we do something different.
Go ahead.
Yes, hi there. Two things. First, I think that I think it's great if we're going to move there to do so planfully, for sure. But I also encourage all of you to do that before you have to do that. And what I mean is before the fee-for-service system has unraveled so many providers that you're sort of forced into it in order to meet anyone's needs at all. And I think there's some evidence that the system is headed in that direction. So although we have to be planful, I don't think we have another 5 years to figure this out. I don't do. Secondly, I applaud all of your efforts on the dual diagnosis people. I think, Commissioner, the work that we've done with CARC and the Health and Hospitals Corporation, the work that you're working with Courtney Burke and the Rockefeller Institute, all are laying out models and issues that I think will best serve people in the future. But I just want to remind everybody that we live down here. And down here is where those people still appear on the pro list. Down here is where various regional offices still really put a lot of pressure on providers, not only to take those people, but to retake those people after they've been arrested or whatever happened to them in psychiatric hospitals. You know, people go to court and the regional offices there encouraging judges to put them back in the group home. So we have a practical problem for which we still need some more immediate and other kinds of solutions other than what I think is going to be the long-term solution.
No disagreement with anything that was stated. The only thing I wanted to mention on the fee-for-service side is, there are some limitations that we have that are imposed by the Center for Medicare and Medicaid Services. There are upper payment limits. There are things we can't work around or that are harder to work around. But to the extent there are opportunities, we do not, and I know Kerri feels this way, we're not trying to force anyone into managed care by reducing or limiting what we can do with fee-for-service. I think the unfortunate reality is that there are limits in fee-for-service that we just can't work around. But thank you for your comment.
And I think one of the things that it mentioned is a real concern is NIDA collects data, proof of the provider associations that work together. And the financial stability of a number of providers is not really great. And we've had issues. Prior to COVID, we had 45% of our agencies with less than 30 days cash on hand. Through COVID and all the federal dollars that have been amassed. But I think that is being uncovered now as we get into 2024. The number of agencies that will be in trouble, I think, are going to be growing. And it's one of those things that there is a sort of there's a need to move quickly, thoughtfully, and to Jerry's point, making sure we get it right. But there is some urgency here, so I think that's what the system is right now. Other questions? We touched on a lot of topics. Oh, Paul, go ahead.
Question for Amir. First up, it's great to hear that they're making an opportunity for our clinics under level 15 through PCMH. I'm curious, and I want to respect the process that we're going through the House, but I'm curious if you talk about potential opportunities for clinics under a managed care scenario. Would that value-based payments be an opportunity to create innovation and create funding opportunities as an example?
I think the short answer is yes. The specificity needs to be worked through, but that's what we want to do. We want those opportunities to be there. We know there's some really exciting pilot projects that were referred to earlier, downstate and upstate, that we want to find ways to support under the waiver and create incentive funds for health plans to encourage those types of models and reimburse on those models. The details are not yet fully finalized, we're trying to balance the accountability versus the flexibility and also get the waiver approved. So there's a lot of moving pieces, but I think the answer is yes, there's existing vehicles that aren't available to all clinics. We are trying to create a way for clinics moving towards some of those vehicles to compensate them through the transition. But there will be opportunities through the supportive housing services or the nutritional services, all through the waiver that I think would benefit some of the clinics or present new opportunities that would be worth exploring.
Go ahead.
So kind of going off of what the gentleman said in the back, the strategic plan is great and having those long-term goals in mind. Is there a stopgap or a help, and DOH isn't here, and I understand that, PWDD and OMH kind of are dealing with the same thing, but those frequent flyers for the hospitals and training for hospitals that what we can and cannot do as providers, we constantly receive feedback of, well, they're in a 24-hour facility, so they just send them home. We have a lot of limitations on us, as Kerri, as you said, for our bureaucracy of it, of what we can and can't do in our facilities. How can we assist for those frequent flyer issues of crisis management?
Yeah, it's a great question, and I'm remiss in not mentioning that in addition to the Medicaid program, right, at DOH, Dr. McDonald running the rest of the health department has been an incredible partner. Sorry, I can't see your face right now. We're having a lot of conversations with the Department of Health around some of the challenges that we experience when we're trying to access, primary health hospitals, emergency departments, when we have people who are, in inpatient settings, and the discharge option is only a group home when perhaps that person, just cannot be supported anymore in a group home, or needs skilled nursing for a period of time before going back. Right, there's a lot of we don't do developmental disabilities, which is just crazy, but we hear that frequently, unfortunately, from all different parts of the system. So we've had a lot of really productive conversations with various offices in the Department of Health. And sitting right behind you is Rachel Baker, who works at OPWDD, who's going to be mad at me now. But has been really leading a lot of our efforts on health equity. So we have a lot of plans in the works, including Dr. McDonald, is taking one of his 4 opportunities a year where he does grand rounds in hospitals and providers across the state to spend the focus of that grand rounds on DD, so we can talk about and help to educate both, how providers, how hospitals and other providers can approach working with individuals that have developmental disabilities, but also educate on the limitations of some of our systems and what does an IRA do versus what's an ICF. And I think, even myself, right, I get just lost in some of the oh yeah, I guess I could do that. And I think for someone outside of our system to try to understand that, we do a lot of work at the regional office level, of one-to-one regional office staff interacting with hospital staff to just try to provide education. We get a lot of pushback from hospitals. Just take this person. It's this person is completely new to our system, right? And the idea that it could take somebody a period of time to establish Medicaid eligibility and then OPWDD waiver eligibility and then go through our PRO process, right? We have to spend a lot of time educating, and we're doing that. So in an effort to support, and I think the partnership that we've had from DOH has been great. And I think, again, when we're looking at ways to, regardless of the payer model, when we're looking at ways to provide integrated care and ensure that providers across the spectrum are educated on what it means to serve someone with a developmental disability. It's another area that I think we're looking to try to leverage some of the payment models to help support that, right? Because nothing speaks to it more than the dollar. So, yeah, I think we have a lot in the works there.
If I could just add on also that in working with the CPAPs and the inpatient units, we have sent out a set of guidelines and standards. It's in draft form now. We expect it to be in final form very soon, and then in regulations. And really what this is kind of laying out what the expectations are for discharging an individual, and how are they connected to what their needs are. So that an individual is seen by a clinic or is referred to whatever that appropriate level of care is within a reasonable period of time. Tying to that, what we were mentioning earlier about the CTI teams and working with the hospitals. Granted, they won't be everywhere, but certainly we're looking at where the greatest need is, and we're going to focus on those areas. Because we know, based on our work with our field offices and the OPWDD field offices, where the greatest number of calls are and where the sticking points are. So that's awesome.
Okay, well, that's the end of the time. I'm just gonna ask the panelists, anything else that you came and you wanted to say that you didn't get a chance to say? You good? Okay, well, I have to say thank you very much. As you can tell, this isn't a one and done, they're talking to each other very clearly. There's a rapport. It's good to see that we've got our Medicaid program, OMH, OPWDD working together, talking. And it's just, to me, I'm very encouraged by this, and I thought it was terrific. So thank you to our panelists very much.